Thank you very much for the introduction. I'm Henry Lim, and my colleague and co-presenter is Dr. Paul Grimes. We're here to present a topic that is very, very important, I think, to dermatology. It is specifically phototherapy. It is one of the older form of treatments, has been around for a long time, but I think it's important for us to continue to be aware of it. So I'm going to start with the presentation, my presentation, then Dr. Grimes would cover the next part of the presentation. This is our cover is primarily on the treatment of psoriasis and polymorphous light eruption using phototherapy, and Dr. Grimes will cover treatment of vitiligo as well as cutaneous T-cell lymphoma, mycosis fungoides. This is my disclosure slide for this particular talk. And phototherapy, I think many of us has been concerned about being forgotten in dermatology. So I'm very pleased that this session has this particular emphasis on phototherapy. And this is a commentary that we wrote a few years ago about making sure that phototherapy continue to be an integral part of our practice. Indeed, fortunately, that has continued to be the case. This is a study that came out in 2018. You could see that based on Medicare phototherapy billing codes, the number of phototherapy sessions continue and reimbursement continued to go up. However, if one dissects this data further, you could see that primarily it is the Excimer laser, which is targeted for form phototherapy, has the increase. And if you look at the PUVA, has decreased, narrowband UVB has slight increase, but not very much. So I think it's important for us to continue to keep that in mind to make sure that phototherapy is continued to be used. What I will do is to cover very briefly on basic principles, and then I will cover the UV-based therapy specifically for the two diseases that I've mentioned to you before. Let's start with some of the basic principles on phototherapy, and this is very familiar to all of you being practicing dermatologists. We know that in terms of UV radiation, it is divided into UVC, UVB, and UVA, which is divided further into UVA2 and UVA1. In terms of phototherapy, we also know that we're talking primarily the effect of UVB as well as the effect of UVA. So we will talk about that as it goes on. In terms of something that we should recognize is that the penetration of radiation. That is, the shorter the radiation, if you look at the left-hand side of your slide, the shorter the radiation, the wavelength, the less penetration it is. That is the reason that PUVA, for example, works better for deeper or thicker lesions because it can penetrate better compared to narrowband UVB. In terms of mechanism of action, this is a subject of lecture by itself, but this is a very brief summary of it. It affects the immune system. That's the reason it works for psoriasis, atopic dermatitis, and so on. It does affect the mast cells, as well as it's used for mastocytosis, and in some cases of urticaria. It works for collagen. That's the reason that it's used for morphea. And it does increase proliferation of keratinocytes. This is used as a hardening treatment for polymorphous light eruption most commonly, and it does affect the proliferation of melanocytes also. That's why it's used for vitiligo. So in terms of guidelines, these are the three published guidelines that are out there. The first one is being psoriasis, which is AAD NPF joint guidelines in psoriasis, was published in September of 2019. The U.S. Cutaneous Lymphoma Consortium had also published a guideline published in 2016, as you can see, and Vitiligo Working Group also had published a guideline published in 2017. I've been fortunate to have been involved in all these guidelines development. So we'll talk about now UV-based therapy. When we talk about UV-based therapy, we're talking about narrowband UVB, targeted phototherapy both in terms of office-based targeted home phototherapy as well as the home handheld type of phototherapy that can be used. UVA1, which is still quite limited because not too many centers has it, is very limited in terms of availability for the patients. And lastly, also PUVA photochemotherapy. That's the reason I use the term UV-based therapy, because PUVA, strictly speaking, is not only phototherapy, it is photochemotherapy because you're adding Psoralen to your treatment regimen. So what I will focus is on narrowband as well as on targeted phototherapy. Narrowband, by now we know, this is the most commonly used phototherapy modality in the world. You can see that the wavelength is very, very narrow from 311 to 312 nanometer. That is the reason that a lot of time we get asked, could patients on tetracycline receive narrowband UVB? The answer is yes, because if you look at the spectrum, the solid line there, there's very, very little UVA in there, so it's perfectly safe for patients who are receiving quote-unquote photosensitizing medication to continue to receive narrowband phototherapy. The list is very, very long. This is only a partial list of narrowband phototherapy. That is the indication: psoriasis, polymorphous light, vitiligo, cutaneous T-cell lymphoma. So partial list, but nonetheless, I will focus on psoriasis and PMLE. Pearl will talk about vitiligo and cutaneous T-cell lymphoma. Let's start with psoriasis. By now, I think it is very well known to all of us that narrowband works very, very well. It works better than broadband UVB. There's the reason no offices nowadays have broadband UVB. All the units that are being sold are narrowband UVB phototherapy. We also know that PUVA, because it does penetrate deeper, it does work better than narrowband, especially for thicker lesions, especially for darker skin patients. But narrowband still is the most widely used one because it is much easier to administer. The advantage of narrowband, we all know, we do it on a daily practice, that it can be combined with multiple topicals as well as traditional systemics such as methotrexate, cyclosporine, azathioprine. John Koo talked about cyclosporine before. So it can be combined together with other forms of therapy that we all use for our patients with psoriasis. In terms of biologics, there are studies here that have shown that narrowband can be combined with the list of biologics as well as small molecule inhibitor, apremilast shown here. So it is perfectly safe to be able to do that. There have been concern, however, that this combination use of narrowband and biologics could increase the photocarcinogenesis. Keeping in mind, however, that the use of narrowband usually is we use it as adjunctive therapy for a relatively short period of time, so I think the long-term risk is truly very, very low, and I personally am very comfortable doing that. And in our guidelines, in the AD guideline that is cited there on the top, also it is said that it is perfectly safe to use it as long as we use it for a short period of time and continue to follow the patient closely. The other part is in terms of cost analysis. You can see narrowband does, if you look at the last point there, the cost of topical medications per treatment, 12 months before narrowband was about 128 pounds. This is a British study. And 12 months after narrowband is 53 pounds. So it's essentially, it does decrease the cost of medications to the patients because of the efficacy of narrowband. Joel Gelfand recently published also to show that if one look at patient-reported outcomes, look at the last bullet at 12 weeks, improvement in skin-related quality of life, narrowband as well as adalimumab is better than placebo, but because narrowband does act faster, so narrowband is better than adalimumab in terms of patient-reported outcomes. So keep that in mind, that this is still a therapeutic modality that can be used. Home phototherapy is something that we all also use quite a bit. Basic model is about 2,500. The more fancy one is about 4,000. It is convenient for the patient. In fact, there is now a PCORI study that is headed by Joel Gelfand at Penn to look at comparison between home phototherapy treatment versus in-office phototherapy treatment. Very easy to study, to enroll. So for those of you who are interested in enrolling patients, please get in touch with myself. I'll forward it to the appropriate person, or to Joel Gelfand directly, who is the PI of this particular study at University of Pennsylvania. There are limitations with home phototherapy, insurance coverage, just like for regular phototherapy, insurance coverage, patient education and compliance, as well as we usually use it at this moment as maintenance versus clearing, but hopefully Joel's study would be able to show that if you need as effective, then it's definitely much easier for us to have justification to use it as a clearing phototherapy at home. The other one that we use, I live in Detroit, so we have temperate climate. We do have a lot of patients with polymorphous light eruption in the springtime, 3 times a week for 5 weeks. In about 80 to 90% of them, they show very, very good response. So it's something that we do routinely treat these patients, and what have been shown, and this is our experience also, no loss of efficacy in subsequent courses. So every spring, many of my PMLE patients will come to see me. We'll start the narrowband hardening for these patients. I'll go over very briefly on targeted phototherapy, that home-based phototherapy in terms of targeted phototherapy Pearl would cover, but these are the two available office-based phototherapy units. Both of them have Excimer laser, and it is used primarily for psoriasis and vitiligo. For psoriasis, you can see this is after one treatment. You can beginning to see central clearing already, and this is before and after treatment. Also, this is very, very fast-acting treatment, so it's very easy to use for patients with localized disease. Noticeable improvement should occur by 6 to 10 treatments, should be discontinued after 15 to 20 treatments without tapering. Usually we just stop them cold. And a few years ago, our group looked at systematic review and meta-analysis of 13 studies on targeted phototherapy. You could see that Excimer laser performed the best. Excimer LAM, which is not as widely available in the U.S., is second best. Targeted UVB, which are available in the U.S., is probably among the group the one that performed least effective. So targeted phototherapy, ideal for localized lesions, resistant lesions following other forms of treatment, hyperkeratotic lesions on the palms and soles, as well as scalp lesions. Limitation, perilesional hyperpigmentation, travel time to phototherapy unit, as well as insurance coverage and expense. This is true for all forms of phototherapy. So to compare phototherapy and biologics, is effective, rapid acting. We know the long-term side effect and the long-term safety, and relatively reasonable in terms of the cost. Biologics, on the other hand, we all know it is very, very effective. It takes a bit longer in some cases in terms of the response. Immune modulators, good safety record, and convenient to administer. So it's very easy for us to prescribe that as long as insurance would cover it. Phototherapy, the main limitations, availability and access, equipment and staff time, patient's time and effort, as well as patient education, because patient has to be told how to use it, especially for home phototherapy. Biologics is primarily the cost, and this, I know you all are familiar, the cost is pretty high for all types of biologics. And however, the message that I would like to convey is that phototherapy should continue to be a useful therapeutic option in dermatology, even in the era of biologic and small molecules, because there's still another treatment modalities that we all can use. And the second point is the important one that I want to emphasize, and unless we as dermatologists continue to do phototherapy, this would be completely lost from the treatment modalities, because we are the only groups that has the appropriate training to support this treatment. Thank you all very much.
Well, it is such an honor to be here this morning, and I want to thank the organizers of the meeting, Daryl, Mark, and Jim, and it is also such an honor to share the podium with Henry. We actually started our careers together. So these are my disclosures, and I have absolutely no conflicts in giving this lecture. So when we talk about phototherapy and oral Psoralen phototherapy, this is a modern history grounded in ancient history that dates all the way back to 1400 BC. And in actuality, Egyptians, Indians in ancient times took the seeds of Amimagus and Psoralen plants. They used the seeds as a paste on the skin in combination with sunlight, and that is the very basis for what we have modernized today as photochemotherapy for vitiligo. In the 50s, Tom Fitzpatrick, Madu, Paddock built on this science, and they laid the foundation for John Parish's seminal work on oral photochemotherapy for psoriasis, and subsequently as we use it today for vitiligo. So in actuality, we stand on the shoulders of great giants. So what are the tools in our toolbox for phototherapy for vitiligo? As Henry mentioned, certainly the therapy of choice now is narrowband UVB phototherapy, but in some instances we still use oral Psoralen photochemotherapy. I'm going to show you some great slides using topical photochemotherapy, which is virtually a lost art. Certainly, several studies on narrowband UVB, and we have a new realm of all the targeted lights, the Excimer laser, their new gain switch lasers, which are exciting, and the very new LED light sources. So regardless of what type of phototherapy device you may be using, there are some key factors that we must consider that impact therapeutic outcomes. These factors are anatomic sites because all the studies show that you get maximal repigmentation on the face and the neck. Age of the patient, children do better than adults. Duration of disease, controversial, but some studies suggest you get earlier, better responses with early disease. That has not been my experience. Certainly duration of treatment. It doesn't happen overnight. You got to be in for the long haul. And lesional white hairs probably impact repigmentation in a negative way. So the work by Westerhoff's group in the Netherlands ushered in narrowband phototherapy into the new realm of dermatology. It's the therapy of choice for children as well as adults. And narrowband is pretty interesting. Not only is it effective in repigmentation, there are a number of studies in the literature, and it's certainly my experience, suggesting that it is a major player in stabilization of the patient, repigmentation. It's great in combination protocols using topical corticosteroids, the calcineurin inhibitors, oral mini-pulse dosing. It's also extremely effective in children as well as in adults. Henry's touched on mechanisms, but key MEK pathways are apoptosis, reduction in Langerhans cells, which is a factorial in immune suppression, upregulation of growth factors from melanocytes, and stimulation of those inactive melanoblasts in the outer root sheet of the hair follicle that then migrate into the skin, into the epidermis for repigmentation. And one thing I want to emphasize, as we move into this new realm of small molecules, the JAK inhibitors for vitiligo, alpha-melanotide, I personally feel very strongly that there will always be a place for narrowband phototherapy, given its impact on those melanoblasts in the outer root sheet of the hair follicle. Henry alluded to this paper from the Vitiligo Working Group. Hopefully for any of you who are interested, this reference should be in your handout, but it's a great guideline reference, protocols in using narrowband UVB. What about comparison studies looking at the efficacy of narrowband versus PUVA? One of the first great studies was a randomized double-blind study by John Hawke's group in London, and they looked at 56 patients with non-segmental vitiligo, twice-weekly PUVA versus twice-weekly narrowband. They looked at those patients who had greater than a 50% response, 64% for narrowband UVB, 36% for patients treated with PUVA. So better results with narrowband UVB. And one of the really interesting aspects of this paper was that color match. And so for any of you who have any experience comparing PUVA to narrowband, very often in PUVA it really takes a while for that hyperpigmentation that you can get very on when you stimulate those melanocytes to calm down. It's substantially less of an issue when you treat with narrowband UVB phototherapy. The other interesting thing in this paper, if you look at the graph that I'm showing here in Yona's paper, at about 48 treatments, you can have with narrowband about a 50% repigmentation. When you get out to roughly 96 treatments, you can achieve 75% repigmentation. And this is a really nice new meta-analysis from Bae in Korea. It was a meta-analysis of 35 studies comprising 1,428 patients. They compared narrowband UVB to PUVA. They also looked at repigmentation per body site. And you can see that moderate responses occurred in 37% of the patients at 6 months, 57% at 12 months, and marked repigmentation in 19% at 6 months versus 36% at 12 months. And again, that gradient in facial responses, maximal repigmentation, as we mentioned earlier, on the face, intermediate responses on the trunk, and we continue to struggle with repigmentation of the hands and feet. Now, I mentioned earlier that children do better. Here I set the bar high. I looked at the studies where kids were able to achieve greater than 75% repigmentation. And I think it's pretty significant here that you see it in 53% of the early new study on, this was the first paper on narrowband UVB in kids. Conwar, 75% of the group. So this is, kids do extremely well. So I think it's pretty tragic that when we see kids in our practice, we don't offer them narrowband UVB. It works extremely well in children who have disseminated disease. This is one of my patients who had long-standing vitiligo greater than 20 years. We treated him with narrowband, and this was at 63 treatments. He had significant repigmentation on the trunk and the extremities. This is another younger patient. He had 36 treatments, significant repigmentation with narrowband UVB. Now you can ask the question, so you achieve repigmentation, are they able to keep it? Well, it varies from study to study. Here I cite 4 studies. They treated the patients and then stopped the treatment, monitored them for a duration of 1 to 2 years. And you can see that the persistence of repigmentation varies from 45% to as high as 80% in the most recent study in 2019. So I think that there is a cohort of patients that we treat with narrowband UVB who probably need to go on some type of maintenance protocol in order to be able to maintain the treatment long term. Now, having talked about narrowband UVB, it's great, it's safe, it's efficacious, but the stark reality is, I always tell my patients, if I had vitiligo, I would never be treated because I could never leave my office. So while it's a great treatment, the stark reality is it can be inconvenience for very busy people, for parents of children who have vitiligo to have to pull their kids out of school 2 times a week or 3 times a week. That's extremely difficult. So we've been doing home narrowband UVB now for over 20 years. We have a very long experience. The type of units that we prescribe vary depending on the extent of vitiligo of the patient. This is one of my patients that you see here who had an excellent response to home phototherapy. So units that are available are the Davlin unit, National Biologicals, UV Biotech, and I'm going to talk about a new unit on the market by Clarify Medical. Here I pulled papers comparing home narrowband UVB or Excimer laser units to in-office. And in virtually every one of these studies, and for time I'll just go very quickly, efficacy was comparable in all of the studies. In the Zhang paper, they did emphasize that in those patients who had really long-standing disease, in-office treatment was superior. The treatments were safe and extremely cost-effective, and this is one of my patients, another patient treated with home phototherapy, no complications at any point. This is the new Clarify system. This is a targeted home phototherapy LED light. So this is a new unit containing LED bulbs in contrast to the older TL01 bulbs. So it runs on a smartphone app. It's standardized for skin color, tanning, the protocol is set, and the interesting benefit is you partner with a caregiver from the Clarify group, and it really, once you prescribe this unit, you're sort of taken out of the loop because they really do all of the heavy lifting for you. This is a before and after at about 3 months, and one other key point to emphasize is, in contrast to the traditional TL01 bulbs that that are used, these LED lights last a very long time. This is narrowband. This is the Excimer laser. This is a systematic review of the Excimer laser in 7 studies, 390 patients showing comparable efficacy to narrowband UVB in the lamps. And it's great for those patients who have limited disease, recalcitrant areas, because I think you're delivering a higher dose on the skin. I couldn't give this talk without talking about a dying art. This is topical Psoralen. We take the 1% methoxylin lotion, we dilute it to an ointment of 0.001, a 0.01%. Great treatment that we use in the summer. Adverse side effects, certainly nausea, headaches. We see that with PUVA because of methoxylin, erythema, edema, blistering. You can get those with both treatments. Photoaging greater with PUVA, cataracts. You've got to do the appropriate eye protection if a patient is on PUVA. And I just want to quickly talk about skin cancer. There are 2 areas in vitiligo. You could ask the question, does the patient have an increase in skin cancer without light? The answer is no. There are no studies really showing an increase because you've got an increase in wild-type P53, increase in glutathione, superoxide dismutase that we think that may be playing a role. So there are protective factors, and we're not seeing it in patients without treatment. And just to end with cutaneous T-cell lymphoma, great treatment. PUVA probably somewhat more efficacious, increased disease survival. This is a great meta-analysis in 778 patients. Better responses with PUVA versus narrowband UVB. And this is one of my patients. So, as Henry said, don't forget about phototherapy because it's old, but it's great. It's cost effective, it's efficacious, and it's safe. We can use it as combination, and clearly the benefits outweigh the risk. So because it's old, please keep it in the back of your mind. And so I thank you so much.